Hello and welcome to my latest blog. Today we're going to talk about the plain language summary of my latest paper, A Pandemic Within a Pandemic. Admission to COVID-19 wards in hospitals is associated with increased prevalence of antimicrobial resistance in 2 African settings. So as I said, this is a plain language summary of a paper that so myself and colleagues from the Centre of Clinical Microbiology at UCL in London, and other colleagues from HerpZed in Lusaka in Zambia and the Institute for Endemic Diseases, or IEND, in Khartoum in Sudan, a paper we wrote about how well prepared countries in sub-Saharan Africa are when it comes to tackling antimicrobial resistance, or AMR. And if you want a link to the original paper, you can find it on the blog, and it's open access, so anyone can read it. So talking about the background to our study, during the COVID-19 pandemic in 2020, we were asked to help by the infectious disease clinical colleagues at the Royal Free Hospital in North London. What they noticed was that on the COVID-19 wards, and by that time it was pretty much the whole of the hospital, they noticed that patients were catching a different set of bacterial infections, which had different resistances to different antibiotics than those that we saw before the pandemic. And if you want to learn more about what antimicrobial resistance is, you can check out the link in the blog. The aim of the study at UCL, so in the UK, was to identify, using whole genome sequencing, whether the bacteria that the COVID-19 patients were getting were related and whether they were sharing AMR genes. At the time, as I was still working with my international colleagues, we decided to see if the same thing was happening in some of our partner sites. Along with my colleagues Dr. John Tembo in Zambia and Dr. Muzamil Mahdi in Sudan, along with their teams, I submitted a grant proposal to the British Society for Antimicrobial Chemotherapy, and we won $65,000, which was my first grant as principal investigator, which was thrilling. And below is a summary of the work we did and what we found, and then subsequently published. Background. Across the world, patients who develop severe illness due to COVID-19, so that's patients who are sick enough to require ventilators to help them breathe, are more likely to be admitted to hospital and acquire bacterial infections whilst they're in the hospital. Because they're more at risk of catching bacterial infections, the WHO recommends rapid treatment with antibiotics, which can mean they're treated before the tests have been completed to identify and confirm what organism is causing their illness. If you want to learn more about the drugs we use to treat pathogens, check out the link in my blog. At the time, there were few reports from resource-constrained settings that looked at how COVID-19 patients were looked after and how they were affected by what bacterial infections might be on the wards, and whether that would affect the drugs that the bacteria would respond to. Our study aimed to identify whether being admitted to a COVID-19 ward, and so being sick with COVID-19, meant you were more likely to get a bacterial infection whilst in hospital. We then compared these COVID-19 positive patients with COVID-19 negative patients on a different COVID negative ward. You can read an introductory blog on the British Society for Antimicrobial Chemotherapy's website, and the link is in the blog. Methods. We enrolled patients from the COVID-19 positive wards and the COVID-19 negative wards if their doctors thought that they might have a hospital-acquired bacterial infection. This was after 72 hours or 48 hours, depending on the hospital. The patients were then swabbed, so if they had a skin infection, it was swabbed. If they had a blood infection, blood was taken, or urine infection, their urine was taken. And then those samples were sent to the microbiology labs to identify if they had a bacterial infection, and if so, what species it was. At the same time, we got hold of infection prevention and control guidelines. So these are protocols that guide doctors, nurses, and cleaning staff on the best way to keep wards clean and patients safe. And we analysed these documents to see if there are any differences between the different wards. We also did whole genome sequencing on some of the bacterial cultures that we collected. Whilst our Zambian site already had Oxford Nanopore sequencing set up, our Sudanese site didn't. Now, usually in this situation, we'd have gone out to the sites to help train them on how to sequence these samples, but of course, during the pandemic, there was no international travel. So we decided to try and do the training online using Zoom, and we recorded the training sessions so that our teams could refer back to them. But after the success of our YouTube tutorial video that we made on diagnosing COVID-19 or SARS-CoV-2 using PCR, we decided to upload the sequencing tutorials too. As a result, we recorded these tutorials and uploaded them to the Pandora YouTube channel and also to the Global Health Network Sequencing Hub pages. You can find the links to these in the blog. These pages have since been viewed tens of thousands of times, and we've had messages to say how useful they've been to other scientists, so it was really worth the effort. Results of the study. We collected 109 patient samples from Sudan and 66 from Zambia, and we found that patients who had COVID-19 or COVID-19 positive were significantly more likely to catch a multi-drug resistant bacterial infection, and those results were found in both countries. The total number of patients who caught a bacterial infection whilst in hospital, and those are both treatable with drugs, so susceptible or resistant to antibiotics, increased significantly on COVID-19 wards in Sudan. However, we found the opposite in Zambia, and COVID-19 patients there were less likely to catch a bacterial infection than non-COVID-19 patients. When we looked at the genome of the bacterial samples using whole genome sequencing, we found significantly more beta-lactam genes present per isolate on COVID-19 wards in both countries. If a bacteria carries beta-lactam genes, it will be able to inactivate antibiotics within the beta-lactam family, and this includes penicillins, cephalosporins, monobactams, and carbapenems. And all of those drugs cover a large number of the routine antibiotics that we use to treat bacterial infections. Bacteria with beta-lactam genes can be really difficult to treat, which means patients are more likely to be sicker for longer. We also looked at the infection prevention and control policies on COVID-19 positive and COVID-19 negative wards. We found that there weren't too many differences, and the main changes were that the policies were more strongly emphasised on COVID-19 wards. For instance, making sure that doctors and nurses wash their hands and use correct personal protective equipment. And you can read our BZAC News and Views article, which summarises the results in the link on the blog. Conclusions. When we analysed our results, we decided that the changes in bacterial infections and the antimicrobial resistance patterns that we saw in COVID-19 patients were likely a result of lots of different factors. These could have included patient factors, such as underlying health conditions like diabetes and heart conditions, the types of drugs that the patients were treated with, and also differing emphases on infection prevention and control in the wards. As a result of this study, the hospitals in both countries have adapted their infection prevention and control policies in an attempt to protect patients from catching antimicrobial resistant bacterial infections, as well as ensuring that nurses and doctors were still protected from catching COVID-19 whilst caring for their patients. Definitely a good result.